Okay, it's about 12:30, so we'll get started. My name is Allison Moran. I'm a second-year pediatrics resident. Probably you guys mostly know me. This is Journal Club. We're going to talk about an article that was published in the New England Journal of Medicine in November, titled Once Weekly Semaglutide in Adolescents with Obesity. And we were just talking about in the room how there's the new clinical practice guidelines from AAP about how to manage children and adolescents with obesity too. So pretty timely information here. And my faculty advisor is Dr. Powell, who is joining us for as much time as she can before she has patients in the lifestyle clinic. So our objectives, we're going to review a little bit about what is known about the treatment of obesity in adolescents. We're going to analyze the recently published randomized controlled trial and determine whether to change our practice based on the information, or at least start to talk about that. So the STEP Teens investigator list, and the STEP Teens is the trial based off of the STEP adult trial looking at the same semaglutide treatment for weight loss. The investigator list for the teens side of things is 35 deep, so we're just going to kind of talk about the top billed people that were on the article, and there's some pretty heavy hitters here, and I'm going to mispronounce a lot of this. Daniel Wieghuber out of Austria. He is the department head of the University Clinic for Child and Adolescents at Paracelsus Medical University. He's previously been the CEO of the Obesity Academy of Austria. Very well published with more than 220 publications, mostly in glucose and fat metabolism. Definitely a lot of obesity, diabetes kind of publishment as well. Timothy Barrett he's had so many letters behind his name that I just pared it down to what I recognized. He's a PhD and some other form of medical doctor from the UK. He has many publications, especially in diabetes, genetics, and other rare pediatric disorders. And he has tons of very fancy titles. Like he's an honorary consultant in pediatric endocrinology and diabetes at the Institute of Cancer and Genomics. He's the managing director for the National Institute for Healthcare and Research at Birmingham Women's and Children's Hospital, where he works, and director for the Center for Rare Disease Studies in Birmingham. So this guy is doing the most in the best possible way with many publications. Then we have Margarita Barrientos Perez. She's an endocrinologist out of Hospital Angeles Puebla in Puebla City, Mexico. She does a lot of research into diabetes and has done other research with the GLP-1 agonists. Injigis, I don't know how to pronounce that, guys. She's from Belgium. She's the department head of pediatrics. She's also an endocrinologist with tons of publications, like more than 70 across the field of endocrinology, including diabetes. Dan Hesse is an endocrinologist as well. He is in Denmark. He focuses on obesity and metabolism. And last slide of people we'll talk about. Aaron Kelly's a PhD. He's the co-director of the Center for Pediatric Obesity Medicine at University of Minnesota. He has NIH-funded research focusing on the treatment targeting underlying biology of obesity, especially focused on outcomes. And he has greater than 150 publications. Lucy Mastrandrea, she has extensive publications, more than 50 across endocrinology. She's the division chief of endocrinology at University of Buffalo and the medical director of the Diabetes Center at Oshie, I believe, Children's Hospital. Ramus Sorig, he is a PhD. He is the senior global manager at Novo Nordisk. Novo Nordisk is the pharmaceutical that was pretty heavy-handed in this trial. And then Silva Arslanian she has greater than 250 publications. She works at UPMC. She is the director of their Pediatric Clinical and Translation Research Center. She's the scientific director of the Clinic for Pediatric Research in Obesity and Metabolism. and she focuses on insulin sensitivity and beta cell function, among other things. So a lot of work, a lot of pretty important people in kind of the field of endocrinology, obesity, metabolism, things like that. A lot of work went into this. Definitions here, you guys probably already know this, but just a refresher. Overweight means you have a BMI in the pediatric world of 85th to 95th percentile. Obesity means you're greater than the 95th percentile, and then you get into, when you get into the classes, you're getting into severe obesity. Class 2 would be greater than the 120th to 140th of the 95th percentile, which approximates the 99th percentile and correlates to a BMI of 35 to 39, and then greater than that would be class 3. So why are they doing this research? Why is it important? Obesity is chronic and progressive with attributable morbidity and mortality. It, just like other disease states, like hypertension, asthma, it's related to dyslipidemia, insulin resistance, hypertension, sleep apnea, fatty liver. It's associated with increased levels of stress, low self-esteem, depressive symptoms, and decreasing your BMI, as you would expect, is correlated with decreased rates of comorbidities. Obesity rates are increasing over time. It's more than tripled from about the 60s, 70s to today in children. And then the majority of obese kids go on to be obese adolescents, and then the vast majority of obese adolescents go on to be obese adults. And Dr. Powell and I were talking about how the converse is true. Those obese children and adolescents that lose the weight tend to continue that weight trend into adulthood. So you don't want to continue with the trend of being obese because it's really to their benefit to try to lose weight when they're young. And then increased medical costs. I just saw one statistic that said that there's a modeling study that's estimated total lifetime cost for a 10-year-old with lifelong obesity to be somewhere between $10 and $14 billion, which is just huge. So management data supports intensive health, behavior, and lifestyle treatment, which is kind of our foundation. That's discussions about behavior, physical exercise, nutrition. There's a threshold effect at 26 hours with increased effect kind of up to 52 hours. So really you're going for like at least a year long. You get better effect if you get buy-in from families, family engagement, and family participation. That in conjunction with our medications like orlistat, which prevents intestinal uptake of fats, which has some pretty nasty side effects. I think most people probably find that prohibitive. Liraglutide is another GLP-1 agonist. They increase glucose-dependent insulin secretion, slow caffeine, and decrease inappropriate glucagon release, as well as acting on the hypothalamus to decrease appetite, which I think is one of the main goals there. Phentermine is a stimulant that decreases appetite. That's FDA approved for 16 and up and only been studied really for a short course, not studied for long-term use, although the combination Qsymia, which is topiramate and phentermine, has been studied for longer-term use and is approved for 12 and up. I believe orlistat and liraglutide are both approved for 12 and up as well. And then we have some off-label use. Topiramate on its own curbs appetite, not exactly sure what the mechanism of that is. Metformin, which decreases glucose absorption from the gut. And lisdexamfetamine is a stimulant that also curbs appetite. Then, of course, bariatric surgery is something I didn't read through the whole, new AAP guidelines, but it's becoming, more, they're approving, talking about it younger, like age 12 and up for those with severe obesity, because it will decrease the shortened life expectancy associated with carrying obesity throughout your life. Where did this occur? Like I said, the STEP-Teens trial is huge. 37 sites across multiple countries: Austria, Belgium, Croatia, Ireland, Mexico, Russia, UK, and United States. So at a quick glance, what do you guys think about these countries and how this relates to our local population? Will this be representative of what we see in Roanoke?
I'd imagine in some of those countries that are obesity would probably be lower than the United States.
That's probably true. And then I was thinking, anybody else?
Well, some to going with that, we have a lower prevalence. Oftentimes when we do see obesity, it's not due to the same factors. So you can have different causes for obesity then. Where here, I think a lot of people think it's more of the food-based. Other places might be more likely to have an underlying problem contributing to it.
Sure, sure. And this occurred from October 2019 through March 2022. As far as is it recently enough to be relevant? Probably doesn't get much more recent. But what else strikes you about this time frame? What might affect outcomes that they found? Yeah, for sure. Just thinking about like the commitment that, you know, any kind of lifestyle obesity clinic takes, time-wise and during the school day kind of thing. It wasn't easier during this time frame to get buy-in. That's what I'm thinking about.
The other thing, it is a long time, and they didn't have a huge population number. Now, they did run it for a long time, the study, but I mean, I think they had like 200 and some people in the meeting across 37 sites over 3 years.
Why wasn't it more?
Right, I mean,
Is that what you're wondering?
to find
Yeah.
patients that would be eligible based on the inclusion criteria.
Yeah, it's a good question for sure.
When it does introduce room for other things to be factors.
It might have to do with the time commitment. I was impressed at their low dropout rate.
Sure.
It was a lot.
They did better than my clinic.
They did like a 12-week pre-period where they'd have to be engaged with them consistently for 3 months before they even started this trial. So.
The how of things, double blind. Oh, yeah. There it is. Double blind. Randomized controlled trial using intention to treat analysis, which is definitely the bar for one of these clinical trial studies. So they're testing superiority of semaglutide to placebo. There's a primary endpoint, which is % change in BMI, and a secondary or confirmatory endpoint, which is a reduction in body weight at least 5%, which Dr. Powell was pointing out they use that as a bar for success with weight loss medications. Like if you don't see that by 3 months, then it's considered a treatment failure. I love this little infographic because it really tells you how they organized things. So there was a run-in period, 12 weeks, where they came and just got the lifestyle interventions, which was counseling about nutrition and physical activity. And then in the supplementary appendix, they talked about offering activity trackers to help encourage that 60-minute moderate intense exercise per day goal, which I thought was cool. I think that would definitely encourage lots of our teens to get active as well. They screened 229 and 201 underwent randomization. Like I said, that offered them 90% power for their primary endpoint and 72% power for the secondary, which is a little bit low. And there's 2-to-1 treatment to placebo. Does anybody have any ideas why they did that?
It's reduced the number of people who are getting the placebo, essentially.
Sure. And then I figured it's because that's how the adult trial was set up too, so they're just kind of following what was already preset. They stratified randomization according to sex and pubertal status, which makes a lot of sense. And then at week 0, they initiated semaglutide at 0.25 milligrams, and there was an increase in dose until they reached the goal of 2.4 milligrams once a week for 6 to 8 weeks, and then there was a follow-up period up to week 75. If patients didn't tolerate the 2.4 milligrams weekly, they were allowed to continue at whatever level of semaglutide they tolerated, which is interesting. Kind of for future, we might use this medication. So the exclusion criteria, I think they all make a lot of sense. Weight change of greater than 5 kilograms or use of medication for weight loss within 90 days, that could probably affect what you see. Previous bariatric surgery, uncontrolled thyroid, presence of secondary causes of obesity like genetic causes, hypothalamic causes, psychiatric conditions like depression within 2 years, severe psychiatric conditions, bulimia, things like that. A history of pancreatitis. There has been not a causative association, but reports of pancreatitis with semaglutide. Something they're worrying about, watching out for. And then calcitonin greater than 50, or personal or first degree relative with medullary thyroid cancer or MPN syndrome, because in a rat model it has been shown to increase the risk of medullary thyroid carcinoma. So those patients should be excluded from taking this medication until more is known about how it affects humans.
They haven't shown it with human models, but nobody knows at this point.
Sure. And then prepubertal patients, why do you think they were excluded?
Because puberty itself will affect
For sure.
everything.
I think so too. Yeah, they're gonna shoot up in height and that'll affect their distribution of weight and things like that. Anybody have any thoughts about the exclusion criteria otherwise?
I do think that the weight change is important at the beginning there, because again, they did that 12-week essentially lead-in time, so people were responding just to lifestyle therapy, they wouldn't be eligible. And that's how we do it in practice, but I think it's important to remember that too. That doesn't mean that we shouldn't try lifestyle modifications first, because if you do get good weight loss, then you wouldn't need medication.
Absolutely. And one of the inclusion criteria for the study was failing conservative lifestyle modifications. So that is absolutely the target group here. So 90% completed the treatment out of both groups, which is pretty great. 87% of the semaglutide completed at the goal dose. I think those are, I mean, correct me if I'm wrong, but those seem like pretty good numbers. And then 62% of the participants were female and 79% were white. Do you guys know anything about, U.S. demographics, Roanoke demographics specifically, and does that kind of represent our population and the population with obesity that we're looking at here?
We're not that much female.
Yeah, I think predominance in the U.S. is male for child and adolescent obesity. Although in their supplementary appendix, they said no predominance specifically, but when I was looking, I saw male. Yes.
How do they classify white? Because oftentimes in Latin American countries, white Hispanics who don't have a lot of, African American will be called white as well. So, and we don't usually do that in this country. So, although arguably maybe we should, I don't know.
Yeah, I can't remember if they talked about white I don't think they did, because it's international. I think they just talked about white. But yeah, definitely in this country, our percentage of like white non-Hispanic people is much lower than 80%. And then I just thought something interesting was that the body weight, BMI, and waist circumference was slightly bigger in the treatment group. That's something that we can talk about. Does anybody have any other comments about how the trial was performed or questions?
When I didn't see any fidelity measures in terms of adherence to protocol. I don't know, and I was looking, I just didn't see any.
What do you mean?
So, like, they talked in the protocol about how they're going to offer lifestyle therapy, and they say virtually is an option, so it can be phone only, it could be video visits, it could be in person. But we don't get any feedback on, what people are actually getting every week. We don't see where people are escalating doses according to their schedule. And I didn't see that in the supplemental info, from what I can see at least.
Sure. Yeah, I didn't find anything else regarding that as well. Yeah, that's a good point. Okay, so they used ANCOVA analysis of covariance. Y'all know ANOVA. We'll talk a little bit about ANCOVA in case it's something that you've forgotten or want to know a little bit more about. So ANOVA, right, is our analysis of variance used to look at the difference between means of multiple groups. And then your linear regression is looking at the relation between two variables, and ANCOVA is kind of like a mesh between those two. So I think the easiest way to explain it is just using a example that's kind of easy to think about. So you take 3 different years in school and ask them to take a test about study skills. When you use ANCOVA, looking at the test results, you get no statistical difference. Doesn't make sense, right? Year 2, year 3 should score higher on a study skills test. Then when you control or take out GPA, because there's plenty of intergroup variability related to GPA, you take that out of the equation, now you see the statistical difference between year 1, year 2, and year 3 related to study skills. So what you do when you take out covariate, which is also known as a confounder, right, kind of an easier term to digest, is that you should decrease the within group variability related to your F test, which is what you're looking at to determine whether you will accept or reject your null hypothesis. So long story short, ANCOVA controls for individual differences that can't be randomized. In this case, we're looking at a change from baseline, and commonly that baseline level is something that they want to be taken out the statistical analysis. Covariance analysis is used often for clinical trials like that. And like I said, it reduces the probability of a type 2 error, which shout out to Jackie Goldman. Two things wrong when there's a type 2 error, right? Like 1, your null hypothesis is false, and 2, you fail to reject the false null hypothesis. So you're failing to find statistical significance. So it increases your power when there are confounders. So here are some of the findings. Top left, we've got the change BMI for baseline. The bottom darker blue line is our semaglutide group, and the top line is our placebo group. You can see an obvious difference in the weight loss throughout the treatment period. So this is just weeks since randomization. They didn't give us any data on that 12-week lead-in. And then you can see kind of that 7-week follow-up period, and there's a little bit of rebound there when they're not receiving the medication. It was a 16%, which translates to a BMI of 30. That's about a 5-point loss in BMI, so that's huge for the semaglutide group compared to it was actually 0.6, and the p-value was less than 0.001 on that. They were way more likely to lose 5, 10, 15, and 20% of body weight compared to placebo groups. In the semaglutide group, 73 versus 18%, as you can see in the top right corner, loss greater than 5%. And then waterfall plots here in the bottom, change in BMI, bottom left is the semaglutide group, bottom right is our placebo group. This just shows you kind of the significant levels that they reached in the semaglutide group, and the fact that way more lost weight compared to the placebo group, which you really, it doesn't look like the intervention had much of an effect for the placebo group at all. There were also improvements in quality of life scores, which were driven by physical comfort in both groups, which I just thought was kind of important to note. And they had improvement with respect to cardiometabolic risk factors, decreased waist circumference, A1C, ALT, and lipids, which were not endpoints not used in the statistical analysis due to like risk of multiplicity and things, but they were observed. What do you guys make of this increase in BMI after stopping treatment? Just seems like maybe more data is needed to know like how long therapy for. We don't know. Would they go right back up to their original BMI, or would they sustain weight loss over time? Dr. Powell just had to leave, but she was saying that studies have shown that they do tend to keep some of the weight off. There is an increase after stopping treatment, but they don't tend to go all the way back to baseline. But I think that's an area for more research for sure.
And traditionally in adult medications that are used for obesity, people tend to, more often than not, cease to go back to their original weight, cease to lose weight when they go off the medicine.
Sure. Think of these lifestyle, this intensive health and behavioral intervention that we talk so much about.
So again, I think it's hard to make any points about that placebo group because, again, you screened out all the people who do respond to it alone already.
Sure.
But even then, you can have people that have some benefit from it.
Sure.
I guess I'm more interested in knowing, those who had the lifestyle changes, like, are they doing like we do, like is recommended that actually works, which is getting the whole family on the lifestyle, or is it just targeted at the kid? Because, if it's just targeted at the kid, I don't know, it seems like a total waste of your time.
For sure. I don't actually remember what they said about family
The
involvement.
protocol did say that they encourage family involvement, but again, there's 37 different sites. How people are doing the lifestyle intervention can be very different at each of those sites, so it's hard to say.
I didn't put up any of the numbers, but they looked at the safety analysis. Of course, there were 436 events per 100 person years in the treatment group and 336, so 436 versus 363, sorry, in the placebo group. So a significant increase there. Mostly gastrointestinal adverse events, 62% in the treatment group versus 42% in placebo. 4% had cholelithiasis, so that was one of the significant adverse events. One had cholecystitis. Whether that has to do with the GLP-1 agonist itself or the rapid significant weight loss is kind of to be determined, I think, but that would be something to consider if we were going to begin using this medication in our practice. And then otherwise it was pretty temporary, like 2 to 3 days and vomiting that were the main complaints of patients in the trial. There was no increase in, or there was a slight increase in amylase and lipase, I believe, but no episodes of pancreatitis. And I believe there was no increase in calcitonin, if I recall correctly, which is something they were worried about. And then some of the risk of GLP-1 agonists in adults is like use with in acute renal failure, which they didn't have any of that, and possibly increasing the risk of diabetic retinopathy. They didn't see any of that. Great. So now, does anybody have any other questions or comments on the findings and kind of what would we do to change? Would we change our practice based off of this research?
So as far as the nausea, vomiting kind of side effect, how frequent was that?
Specifically, I don't remember, but 62% of the treatment group had GI adverse effects, and the majority of that was the nausea and vomiting. And the majority was temporary. Like if you recall, 87% completed the trial at the goal dose of 2.4, and that's kind of the point of the step up dosing, is to decrease those side effects. So more tolerated than if not, it would seem. It's also interesting that a whole 42% of the placebo group had GI adverse events.
So for me, I think one of the things I always think about is what is the alternative that we would be offering to people? And here they compare to a placebo group. We have other alternatives too, right? Liraglutide's already approved and things like that. So I'd have to look more into which of those then is one that you need to start someone on.
Yeah, so I don't remember the numbers, but looking into liraglutide is, it didn't show the efficacy that this shows. I think what was pointed about this, Dr. Powell pointed out that it just about equals the decrease in BMI rates that you see with bariatric surgery. So a huge change with just medication. I don't think any of the others, I had numbers for you, but I don't think any of the others quite measure up. Liraglutide is also a daily injection. I don't think there's an oral form of that one, but it could be oral, but compared to a weekly injection, which is just something to think about for quality of life.
For patients with diabetes who have to inject, I think is the biggest deal.
Sure.
here. They actually didn't have a lot of diabetes.
No, there was one person with obesity and a comorbid condition. I don't remember how many of them had diabetes, but it was few. This was definitely more targeting just the weight loss. All right, so do you guys think this has a role in primary care, or is this only for our obesity and lifestyle clinics across the country, which we are very fortunate to have one here, but they're definitely not as prevalent as they should be.
I mean, I think patients, when they start demanding it, regardless of, you know, kind of what we think, but they need to know the potential side effects. I mean, they need to.
It actually has like a script of what you can say for the medication, which I thought was great to read through.
I think the important thing, like was touched on, is this is a small population that we're looking at, and it's all kind of post-pubertal. So there's still some limitations on who this could apply to. And I think the important thing is, this is fantastic to hear. But if you have a kid in your primary care clinic who you see that they have obesity, but you're not sure how much fire there's going to be, they're screening for all these potential complications. If you don't have great follow-up, you could end up with these complications that hadn't been picked up on the study, and you wouldn't know because some of these people may just not follow up. So it's just something to be aware of if we were to try large-scale application.
I think the other thing is all of these patients that are getting the semaglutide are also in regular healthy lifestyle coaching, I'm a dietitian, activity specialist, and all that. So I don't think I have to be searching many of the clinics here to give that at the same time as giving the medicine. So I still think having them in a clinic, one, to make sure they won't succeed just on lifestyle alone, but also having that component based on the study, they had both. They didn't just have the medicine.
For sure.
So I wouldn't just for medicine.
Yeah, we don't know what would happen, and like when they lose weight, but what would happen when they stop? I mean, if you haven't targeted kind of underlying lifestyle habits and things like that. And what about our younger kids? Dr. Powell was talking about how there's been data that shows that exercise alone, increasing muscle mass, helps to decrease obesity in our younger kids, which is just, I think, quite interesting since, we took away daily recess and gym and everything, and the focus is on being in the classroom and focuses on academics. Just interesting to try to help those kids in kind of a different way without the medications. I feel like it would be hard to ask a 7-year-old to tolerate side effects from something like this. You wouldn't want to. All right. Here's some references.
Oh, yeah. Did they mention like cost of this medicine?
Oh, I talked about it with Dr. Powell, and like $2,000 to $3,000 a month. Your copay, if it's covered, might be a couple $100s. The reps do have a little QR code that you can scan to see if it'll be covered by your insurance, but cost is definitely prohibitive for this medication. They have a lot of people using like the Qsymia, the phentermine and topiramate can be expensive on its own, but they have people prescribing phentermine and topiramate separately because those are a little less expensive when you prescribe separately, and then you can take them at different times of day to kind of balance out their side effects. And so that's like a more commonly used thing, right? But yeah, we'll see. Anybody have anything else? Anybody online? Okay, thank you. That's a nice day.